Thank you so much, Dan. I'm just going to share my screen. Here we go. Can everybody see that?
Yep, we can see.
Great. I think I recognize Karen's voice there. Thanks very much, Karen. And thank you to all of you for your time this afternoon at your lunchtime hour. It's a pleasure for me to give you kind of an update and a highlight of where we are currently with the WHO Icd-11, specifically the chapter on mental, behavioral, and neurodevelopmental disorders, and also give you a sense of the decade-long process that went into developing this specific chapter, the clinical description and diagnostic guidelines, with an emphasis in the ways in which WHO prioritized the engagement of global clinicians in the process, such that the core and overarching principles of maximizing the clinical utility of the guidelines and its global applicability were met through this global engagement process. And I'd like to end with giving you a sense of what we are doing with our online trainings for the WHO Icd-11 section on mental, behavioral, neurodevelopmental disorders, and to leave you with some guidance on how all of you can sign up for the network that I'll mention as part of my talk and participate currently in the pilot testing of this online module. So as many of you know, in May 2019, the WHO member nations at their World Mental Health Assembly, or Health Assembly rather, that year focused on the Icd-11 ratification. And it was approved by the World Health Assembly in 2019. And it was really the first time in almost 30 years since the Icd-10 was developed and published and ratified that we saw this kind of comprehensive revision take place of the guidelines. And so what we see now is that the Icd-11 has incorporated kind of the advances in clinical science, basic science, epidemiology, and public health research has taken place over the last 3 decades into the various proposals, and now the approved proposals for various classification of all of the disorder groups, and this includes the chapter mental, behavioral, and neurodevelopmental disorders. So specifically, the version that was ratified in 2019 and initially set and allowed for a more broad use by member nations was the morbidity and mortality statistics. And so if you're interested in what this looks like, many of you may have already accessed this platform online, but you can find what was the beta version is now the published version of the linear structure of the Icd-11 MMS, which includes, as you see here, all of the conditions and related health problems in the Icd-11. And here, situated in chapter 6, is the mental, behavioral, and neurodevelopmental disorders. For the purposes of this talk and the purposes of the work that I and Dr. Stein and many others on this call have been participating in over the last decade or so, relates to the development of kind of a parallel version that's being developed, which includes more elaborated, comprehensive clinical guidance for mental health professionals on the various mental, behavioral, neurodevelopmental disorders. And this is the clinical descriptions and diagnostic guidelines for Icd-11. You may recognize this as the blue book from Icd-10. The initiatives that I am about to describe were led by the WHO Department of Mental Health and Substance Abuse based in Geneva at the Secretariat, but also really involved and engaged WHO collaborating centers across the world. And later on in this presentation, I'll share with you the many centers that participated as field study centers that served as kind of nexus and hubs in their regions, which covered all WHO global regions of the world, to really facilitate the implementation of these crucial studies, again, aimed at enhancing the clinical utility of the guidelines. In addition to the WHO collaborating centers and the WHO secretariats, these more physical centers, what we have are, online networks and kind of advisory groups and working groups that engaged experts from really across the world, across all diagnostic areas within the mental, behavioral, and neurodevelopmental disorder field. So the ICD-11 CDDG, as it's known, the Clinical Description and Diagnostic Guideline development, was a decade-long process and was scientifically rigorous, as I hope I'll leave you with after this presentation. And I'm happy to share references of all the papers that I have screenshots of in my presentation through Sandra and Professor Stein and others on this call, if you could kindly help me do that. And it involved the engagement of global clinicians through this program of global field studies that were done in up to 6 languages. So it's multilingual, and it was a multidisciplinary participation. So it involved, as you'll see, clinicians who were primarily psychiatrists, some primary care doctors who participated in the studies, a large proportion of psychologists, and we also were thoughtful about engaging other important mental health professions that play a role, a more major role in some parts of the world in purveying a mental health care, such as nurses and occupational therapists and social workers. The focus was in enhancing these specific implementation characteristics of the ICD-11, the clinical utility, reliability, and the global applicability of the guidelines. So how acceptable and were they to global clinicians, and did they, for example, fit the types of patients that they saw in clinical practice? And this was particularly important because the ICD, as you well know, is a tool that is used across the world in diverse clinical, geographical, and cultural contexts. So it's very important for WHO to enhance the ability of the guidelines to be applied in these diverse contexts. The ICD-11, because the last version was done 30 years ago, as I mentioned, really captures some of the innovations and the scientific data that's pointing towards kind of more substantial changes in some diagnostic areas, which I will not get into as part of this presentation. But if you sign up to be a member and access the trainings, our first module actually is devoted specifically to providing clinicians around the world who participate in these online trainings with substantial detail around the rationale and the description of the innovations that are introduced into ICD-11. For example, in the personality disorders, where we see kind of, quite substantial changes from ICD-10 in the way that ICD proposes clinicians apply these guidelines to diagnose patients. And the development was guided by, as I mentioned, engagement of clinicians, real life clinicians working across the globe with patients, with people who potentially need care, and well poised to provide WHO with really concrete and important data on how well the guidelines could be applied. And these weren't just survey studies related to, do you prefer these guidelines for ICD-11 versus ICD-10? As I'll describe, they were much more comprehensive than that and employed a case-controlled methodology. I'd like to say that I noticed some familiar faces on the call already, or names on the call already, because many of you have contributed in varying ways to the field study process. Dr. Stein, for example, was on the working groups of several different diagnostic areas for developing the field studies and identifying the key research questions for field testing across the globe through the networks that were built to do this field testing. In addition, Many of you are members of the Global Clinical Practice Network, which I'll describe in just a second, which really served as the participant pool for this rigorous field testing process and for the implementation of these case studies that, as I said, went beyond just do you prefer this versus that, but really asked clinicians in a randomized fashion and a blinded fashion to the degree we were able to blind clinicians to apply the guidelines to standardized case vignettes, which again were developed through consultation with experts around the world and then tested with clinicians around the world before being used in the field studies, again, in kind of the vein of enhancing global applicability and being respectful for the different ways in which patients present for specific disorders across the world. So what were these field studies? So first, I'm going to go very briefly into these. As I said, again, we have unit 1 rather of the online program that you'd be welcome to participate in, which provides substantial detail as well as links to the PDFs of all of the papers that I'm going to be just sharing screenshots of. So there were several formative studies that were done. Here are two, the psychologist perspectives on the diagnostic classification of mental disorders and the WHO Global Survey of Psychiatrists' attitudes towards mental disorder classifications. And I just want to mention that this included clinicians from South Africa who were part of the South African Society of Psychiatrists who provided feedback and participated in these two initial studies, which really helped set the overarching architecture of the chapter on mental, behavioral, and neurodevelopmental disorders. So clinicians were asked questions, and maybe potentially some of you on the call today were participated in this study. They were asked to, for example, help cluster disorders together, and they were asked to provide rationale for those clusters. They were asked to provide input into kind of what the eventual linear structure would look like, again with clinical utility in mind, so that when the guidelines were eventually out in the field, as they will be in the very near future, and as versions of them are already in use around the world, that they really do serve as a valuable tool for detection for clinicians and as kind of the basis for then care and treatment. And that's to say, those are the clinical purposes, which what I'm going to be emphasizing for the purposes of this call. But the ICD, as you may appreciate, has really a multitude of uses around the world for things from all the way from policy making, for obviously collection of really important health information, monitoring epidemics, for assessing burden of disease, et cetera. And in all of those cases, we highlight this in our papers and also in the unit 1 of the online training. Underlying all of those other uses is this idea of clinical utility, because it's the first place of contact with people who potentially need care with the health system. Following the formative studies, which again helped the general structure of, help guide the general structure of the chapter and the CDDG, the Clinical Descriptions Diagnostic Guideline for mental, behavioral, and neurodevelopmental disorders, we implemented evaluative field studies. And to really just organize it cognitively for us, there were two major arms to this work. The first were internet-based studies, and these are the case control field studies that I alluded to a little earlier, which were implemented through the Global Clinical Practice Network. And they again examine the accuracy and consistency and clinical utility of the diagnostic judgments that participating clinicians made using the Icd-11 versus the Icd-10. In some diagnostic areas, we also compared it to the DSM, because that was relevant to some of the research questions, for example, in dissocial disorders and disruptive behaviors. That was an area in which we also included the proposals from the DSM, which as Dr. Stein mentioned, Icd-11 is being implemented after the DSM-5, but a lot of the development process of DSM-5 and Icd-11, there was overlap. And so Icd-11 included working group members who were played substantial roles in DSM development. For example, a colleague at Columbia, Dr. Michael First, that many of you may know, was an advisor for and part of the field studies coordination group for the Icd-11 as well. And so we were able to really use that body of work to help hone and develop these online field studies. And the data from these field studies were really essential, again, because we were in the process of finalizing Icd-11 guidelines. So whatever we found in the studies was used to guide the final sculpting and pruning of the guidelines and improvement of the guidelines, so that we hope that they represent really high quality material that fits with these principles of utility, consistency, and applicability. That's the first arm. The second arm is the clinic-based studies, which were implemented via international field study centers. Many of them are WHO Collaborating Center. And this University of Cape Town and Dr. Stein is actually an international field study center. So it's likely that you, in your work over the years at UCT, have participated in some of these clinic-based studies, which were implemented in South Africa, as I'll point to in a few slides, or through the Global Clinical Practice Network. And we thank you again for your time and input, which has been really valuable, as I said, in sculpting the final guidelines, but also in developing these training modules that we're going to be looking at. So what is the Global Clinical Practice Network? I'd like to spend a little bit of time here. One, because I'd like to invite you to participate if this is something that you find worthy of your time. We really hope that you will. And it's the way becoming a GCPN member is the way in which you are able to actually access the modules. But I hope I'll leave you with some information about the diversity of the network in a way that may catalyze your own thoughts about ways in which WHO or you as a global researcher could utilize the network to answer really important research questions beyond the Icd-11 or potentially linked to the Icd-11 to help advance the field. So we had our paper come out in Lancet Psychiatry in 2015 that described the network in greater detail. The GCPN is a practice-based research network, essentially. So it's an online network of clinicians, thousands of clinicians from around the world who have signed up. And in the early stages of this network, at least, the focus was in developing and participating in studies for the Icd-11. It also happens to be one of the largest practice-based research networks in global mental health, and actually in all areas of health. We need to quantify that in 2021. I'm not sure if that still stands, but that's what it was in 2015. That was true in 2015. As I said, it's composed of individual mental health professionals, and it really captures a lot of the diversity in discipline and geographic location and country and area of expertise and then professional context in which clinicians are working. So we have, again, this large group of clinicians from around the world who are well poised to answer really important questions on what does mental health look like out there in the field? What are the needs of clinicians? And again, in this first phase, all of the research questions were really focused on the Icd-11 and developing the Icd-11. So as of February 1st, 2021, so somewhat fresh off the presses, not quite the March 1st data, but we had 16,091 members from 160 countries. 40% of them were from low and middle income countries. And the breakdown, when you look at this regionally, were The Africas are 3%, the Eastern Mediterranean region here in yellow is 3% as well. We have 0, so South and East Asia regions as 5% here in the purple or fuchsia color. The Western Pacific, which is the red, which includes Western Pacific, Asia, and Oceania, it's 26%. The Americas are 24%, and the 40% of the network happen to be from Europe. And so those numbers these are large numbers, but as you see, there's 453 clinicians from Africa, which, at the denominator of total number of clinicians in each of these regions varies. So please take that into account. We would really like to increase participation from across the world. And we've been working closely with a lot of colleagues on the African continent.
The doctor committee beginning at, oops, I thought it was beginning later.
I think someone's on mute, or they potentially are asking me a question. If you're asking me a question, I really apologize. I didn't catch it, but I'll make some time for it after, if that's all right. As I was mentioning, we really want to enhance the representation. And so we would really appreciate your guidance or your participation in the network, or ideas that you have to expand it further. I know several have already emailed about this. And another piece of information that's important is that 92% of clinicians who've signed up for the network are currently seeing patients. So again, it's a really important window into clinical practice across the world. And almost 60% are in some sort of supervisory or leadership position, which again is really important as we start disseminating training modules, as we start using the GCPN as a conduit for sharing, for example, evidence-based practices or best practices for example, suicide prevention is an area of interest. Or in this case, we're using the GCPs again, as you'll see, to pilot test and do the first round of dissemination for the Icd-11 training. So it's a really valuable tool, we think, and having 60% of members have some sort of leadership role is really quite important, as they can potentially serve as ambassadors for the work that we are doing. Here we have the list of countries with the greatest number of registrants. We have China at number 1, the US, and Japan, who are part of the network. And I would like to mention that you can register into the Global Clinical Practice Network in up to 9 different languages. And Chinese, which I understand is not a language, but I'm referring to the text. People can sign in through Chinese and Japanese as well, which is why we've been able to capture a lot of clinicians from these countries. I also looked up the South Africa data. We currently have 136 clinicians from South Africa, and you're actually number 18 out of 160 countries. So if you do the math, you can imagine that a lot of the countries we have 1 or 2 mental health professionals there to get that 160 number, which is fine, because in many countries there's just 5 mental health professionals, for example. And so having 1 out of 5 represents 20%, so it's not negligible. But we would love to see South Africa jump higher and to have more clinicians participate in the kind of final studies of the Icd-11, and then moving forward the various studies that we can potentially implement through the network to again ask really important questions for our field. As I mentioned, the clinicians are able to register in up to 9 languages, and we're also able to capture kind of a significant portion of a non-trivial portion of other languages in the network, which again is really important when we think about doing these research studies. We can't solely think about doing them in English. We're just not going to capture the reality of clinical practice across the world if we do that. So it's really important that we do our studies in up to 3 languages, and that's actually something that we've been able to do, luckily, with really limited resources. Again, thanks to the participation of WHO collaborating centers across the world. We also have very diverse disciplinary distribution, and I'm not going to go through the details of these. I'm really happy to share my slides again with you if you'd like to take some time to review them again and metabolize them and think about the ways in which you can imagine this network contributing to the field. I'm happy to share my email address as well if you'd like to follow up. We also have all areas of expertise that specifically in mental and behavioral disorders. These are the ICD-10 categories because at the time of registration, the ICD-11 wasn't out as yet. So this is what we see: mood disorders, schizophrenia and related disorders, anxiety disorders as the top three, which is not surprising when you think of the bread and butter kind of disorders that most clinicians see in clinical practice. The GCPN really, to summarize, provides us this direct window into clinical practice. And the benefit of them is that they're a committed group of clinicians who've been participating over the last 8 years or so since the GCPN really took off. And it was kind of born out of the formative studies that I mentioned to you, the WPA, IUCIS studies. IUCIS is the International Union of Psychological Sciences. So some of those formative studies, clinicians who participated in that wanted to continue to be able to contribute. And so, it's a really great model of allowing clinicians to participate if they're just in even private practice. They don't have to necessarily be affiliated with a large academic institution, in order to participate in research studies, which really hasn't been done before to this scale. And, one of the benefits that we have by doing this in through the 2000s and into the 2010s and into the 2020s is that we have internet access and we can do these large scale forms of efficient data collection, which are fast and secure, multilingual, in rapid form, in a really rapid way, which was not really feasible for ICD-10. And the takeaway from the GCPN story is that through these case control studies, we've now implemented 20 plus large scale studies that cover all mental and behavioral and neurodevelopmental disorders. And if they don't cover them yet, they're in the pipeline. Some we may not cover. That 20 plus number doesn't really make sense if you know that there's actually fewer diagnostic areas than 20 in the mental, behavioral, neurodevelopmental chapters, but for some areas, for example, psychotic disorders, schizophrenia and psychotic disorders, we've done multiple studies to ask various different types of research questions. So that's where that 20 comes from. And these were done in up to 6 languages. So we do them in Chinese, Japanese, Spanish, Russian, French, and English. Those are the 6 languages. We would love to do them in other languages, but we just did not have access to those resources. We have, over 300 publications in top peer-reviewed scientific journals, and we're actually in the process of updating the gcp.network website for members of this network. Many of you had already seen it. I had emails from people saying, something's wrong with the site. Absolutely true. We're in the process of updating it. But on this site, you actually have access to the bibliography that has all of these papers listed. And in many cases, depending on the access policies of the journal it's published in, and whether you've logged in or not, whether you're behind this kind of secure firewall or not, you may have access to the PDFs. And again, if there are specific papers that you would really like access to for your work, please feel free to reach out to me. And if I can find the PDF of them, I'm happy to share that. Although I imagine UCT has a lot of relevant licenses for journals to have access to them there. And really, the work that we've done with the GCPN has been able to significantly alter the terrain and the empirical base for classification, clinical utility, and consistency. And so we are pretty proud of our work. Here, I've taken some screenshots of just the last kind of 3 big papers that have come out. You see Dr. Stein as through his membership and his consultation over the guidelines for obsessive compulsive related disorders is a co-senior author on this paper. So we have these studies which are out of the the studies that I mentioned before, the case control studies in the GCPN, we've been able to look at obsessive compulsive and related disorders, anxiety and fear related disorders, and DBDD, the disruptive behavior and dissocial disorders, just as an example. I just, to catalyze you thinking about the ways in which this network can be used as well, beyond just the training, which we're going to transition into in just a second, we've been able to ask other relevant questions outside of the ICD-11 already. And one study that I worked on with Dr. First was related to diagnostic classification and how do clinicians actually use classification systems out there in the world. And it's an interesting paper that also helped guide our thinking for subsequent studies and thinking of how we want to design trainings for the ICD-11, but what other products would be of value to clinicians, whether it's an ICD app, for example, or an online, easily searchable version of the guidelines. This really helped us think about these products. And just on a side note, potentially some of you who are members of the network have been invited to participate and have already participated in this. I know this to be true from looking at the names for a few minutes before we started. We actually received funding to do this longitudinal study looking at the impact of the current COVID pandemic on clinical practice, mental health practice, and well-being of mental health professions around the world. And the study was implemented through the GCPN. So moving on to the second type of studies briefly, we have these clinic-based field studies that were done via physical centers around the world. And here we have a list of the centers I highlighted. South Africa, University of Cape Town was one of the centers that played a very substantial role in data collection. And the papers that came out of these clinic-based studies, which focused on clinical utility, again, assessing clinical utility as the guidelines were applied to real life patients, but also on the clinical consistency of the guidelines or reliability. And here are the two major papers that came out in World Psychiatry over the last couple of years. I want to mention that South Africa was one of the sites in which we did this. I just cut the table. This is not exactly what the table looked like. So that the South Africa component was right near the title, but so the Valkenburg Psychiatric Hospital in Cape Town participated. Clinicians from this hospital participated in the study. Again, thank you if you were one of those clinicians for your contributions. Here what we have, I'm not going to focus again on these data. We delve into them in Unit 1. Happy to forward you the papers after, but really just the takeaways that we did these studies across the world and involved clinicians in all of these parts of the world, including South Africa. What we found when we were looking at concurrent, so joint rater reliability, inter-rater reliability, is that we have kappa values, which is a measure of reliability, to be quite high. So the overall is 0.87 for schizophrenia, for example. What we find in South Africa, it was slightly lower, 0.71. And we also looked at clinical utility ratings by country for 3 core questions: ease of use, goodness of fit, clarity and understanding of the guidelines. Again, clinicians from South Africa provided feedback on these guidelines. We see quite and extremely joined together. So these two columns, we have 93.2% of clinicians captured saying that they were quite and extremely useful to them. This is just the higher order data. We obviously collected a lot more kind of nuanced, granular data on what elements of the guidelines were particularly helpful. Was it the qualifiers? Was it the way in which the essential features were formatted, etc. Here we have the goodness of fit data again. Here's the South Africa data. Again, I can share these slides with you if you'd like to take a look at the data in greater detail. So now moving on to the part that's likely of most interest to you. Since 2019, it's already been a year and a half, but it's been a very interesting last year with and challenging last year around the entire world. So some of the work with implementation has kind of taken a backseat to dealing with the pandemic, for example, but we're really starting to see rollout of the ICD-11, and our kind of focus on this part has really been on setting the infrastructure for training so that when countries adopt more formally the ICD-11, for example, for collecting data and for use in clinical settings, for coding, that clinicians will be trained to do this already. And the mechanisms of we're doing this is, again, engaging clinicians around the world. We've put together these advisory groups that are going to help establish concrete next steps. They involve members from across the world. In consultation with them, we're thinking about what are the training modules that we need to develop? What are the areas that we need to develop in these? How do we provide, what does the content within these training modules look like? Is it enough to show guidelines? Do we have to show rationale? And we're doing that in collaboration, not just with content experts across the world, but we also are working with a learning management system team that's providing us with the ability to think through the ways in which we're presenting material. How do we make this most engaging so that it sticks to with clinicians and they're best prepared to implement the new guidelines in clinical practice when that is the case. Obviously, we've also done in-person trainings around the world. That model is more resource heavy, and so we really started to focus on these online modules. So right now, what we have is set up this Global Mental Health Academy. I do want to say, though, that we are still working on final approval from WHO for the online units, which is why we're still in the pilot phase and which is why it's only being shared with global clinical practice members that we have permission to do that thus far. And we have a module at the end of each unit where members can provide us with structured feedback on what the experience was like for them to both navigate the platform, but also the content of the guidelines. What did they feel was missing? Could we have emphasized certain elements more strongly? So it's this online platform. We cover all of the mental and neurodevelopmental and behavioral disorders. We're not at 15 yet. We're kind of, consistently working on them. We have about half of them done. The content's developed by experts in the field, and then the WHO Collaborating Center at Columbia for Global Mental Health, at which I work, and which Dr. Jeffrey Reed, whose name you may recognize from, it's attached to ICD-11 very strongly. He was at WHO, he was the senior project officer leading all of these field studies, and now he's a colleague at Columbia at the Collaborating Center. So we work closely, we continue to work closely at Columbia, and we kind of do the final preparation of the training materials. It's really based on best practices and empirical data from the field testing that GCPN members worked on. And we're hoping that it's easy to navigate, and we have a voiceover, that presents the material in easy, and we present the material in as easy English as we can to make it really accessible to as many people as possible. It is only in English at the moment, but we really are working very hard to work with, again, collaborating centers, get funding to be able to do this in various different languages. We understand really the importance of that, and we hope to find the partnerships to be able to do that. So when you sign up to be a GC, you'll receive an email intermittently. We do them in batches because it's still in a pilot phase. So if you sign up in the next coming weeks, in early April, you'll get an email from me, more officially, not from my Columbia address, from the WHO address, and an online platform inviting you to participate in the studies. You'd come here, you click to access the training units, you log in, and you get access to these units here. And the ones in blue are the ones that are active currently and that people can participate in currently. So we have Unit 1, Welcome to the ICD-11. Again, talks a lot about kind of the more dimensional approach, the more life course approach in ICD-11, the elimination of mind-body dualism, how are we handling gender incongruence, for example. That's all in there, so I refer you to that. We also have papers associated with each unit, PDFs of them actually. So, we're happy to be able to give you access to this information if you may not be able to have it through your own institutions, which isn't the case for many clinicians in many parts of the world. So we're happy that we can make that information more accessible. So So what do these units look like? So each unit has a general structure. Unit 1 is slightly different because it's so much of the introductory material, but it has unit objectives. Then it shows you it doesn't replicate the diagnostic guidelines verbatim, but really talks about the core and essential features. I have screenshots, so you'll see what that looks like in just a second. Overarching changes, specific changes for each of the disorders. Other relevant sections, for example, co-occurrence rules, and then key points to summarize all of the information. Through this module that has the diagnostic guideline information, we have these quick knowledge checks within the unit, which allow clinicians to kind of more actively learn the material. Followed by these two modules, we have 2 clinical cases that clinicians have to apply the knowledge that they've just picked up to the clinical cases. And these are the same clinical cases or similar clinical cases that were tested in the case control field studies in the evaluative phase of the work. And we use them in-person workshops as well. You have a final knowledge check, which is 10 questions, and a unit evaluation. It takes about an hour and a half per unit. And they're not linked. You know, clinicians, we understand, have limited time. They may not want to sit and go through all of the units if, you know, it's an area that's not of relevance to them. And so you can do this on a per unit basis. And one other thing that we're able to provide clinicians who participate is that for each unit completed, you get a certificate of completion if you meet certain criteria, one of them being that you need to get at least 80% on the final knowledge check. We're looking at the data coming in for that right now. It's kind of interesting. So for example, people are not doing as well with the mood disorder guidelines. So we now have to think about what is it something that we need to improve with the online module? Is there some clarity that needs to be provided around some of the guidelines? And it's not really that different from some of the findings in the clinical cases, case control studies. So these are my last couple of slides. So here's what the anxiety disorder unit looks like. I hope you all register for the GCPN if you wish to, and then you'll get to actually do this interactively. So here we have the units. So just 2 unit objectives. So describe the essential features and key changes introduced to ICD-11 for this area, and be prepared to apply the guidelines in your clinical practice. Then this is the module 2 I mentioned, which goes into the diagnostic guidelines, the key changes. Here we have overarching changes for ICD-11, core features of anxiety disorders and ICD-11, a summary of the essential features. So really the focus on apprehension is a way to differentiate between social anxiety disorder and separation anxiety disorder, for example, or panic disorder, characteristic behavioral manifestations, symptom duration requirements, differentiations, kind of the boundaries with normality, but also with other related disorders or similar disorders with similar presentation, and then this kind of functional impairment piece is stress and impairment. As I said, we talk about the key changes as well for each of the disorders. So that was kind of broadly for anxiety disorders. Here we have an example for panic disorder, and we break the material up so it's not as overwhelming to people. I also want to note that actually the artwork that's part of these modules, we're really happy to say it has been developed by people living with serious mental illness who are part of an NGO that we work with really closely in New York, which some of you may know because they use this clubhouse model for people with serious mental illness, and they provide housing and support. And we work with the one in New York City, and we obviously have permission from all of the artists, and we acknowledge all of the artists, and we're hoping to also provide them with a stipend for their work to support them in that way. So this artwork is from an artist from that NGO. We have these other areas after the specific areas of anxiety disorders, for example, are covered. So changes in co-occurrence rule. As you can see, it's formatted in a way that we think is, a little bit more interactive than just reading things off the slide. We have key points at the end. Here's what our clinical cases look like. They all have voiceover. Tara, a 25-year-old website designer, was brought to the local community health center by her closest friend to be evaluated because of severe anxiety symptoms. So you go through this entire case, it's animated, and then you have questions to answer and think about in terms of Tara's presentation. So is Tara's experience of anxiety, what is the focus of apprehension? Multiple social situations, escape might be difficult, having an unexpected panic attack, multiple social situations in which she's separated from a friend or someone else. What diagnosis do you think is appropriate for Tara? So it just doesn't jump from that last question to this one. I'm just taking a subset of the questions, but they're asked to make a diagnosis based on the case and based on what they've learned. And they're given some minimal feedback or asked to refer back to the guidelines. You can actually do the unit as many times as you like. Here's another vignette, clinical case. Ken was referred to me by his family physician and wife, Amaya, because of conflicts that have arisen in their marriage. And it continues with that. Again, we want to think about Ken's case. According to the guidelines, Ken's excessive separation anxiety would be better conceptualized as a personality disorder. So you have to think about that kind of differential diagnosis there. And then at the end, you have this final knowledge check. You have questions that are more simple, true and false, like the presence of recurrent panic attacks always warrants a diagnosis of panic disorder. So if you go through this module, and as clinicians, you may know that that is not true. But we also have cases. So John reports feeling on edge most of the day for the past year. What is the best diagnosis for him, given the guidelines? You are given your score. You are allowed to review the answers to the quiz, and then you have to retry it. And if you get 80%, you're given a certificate of completion. And finally, you have this end of unit evaluation where we ask learners to provide more concrete feedback. And really what we are is we're in the GCPN serving as this early adopter phase for adoption, in this case, adoption of the Icd-11. And, we really would appreciate your input. Kind of the next steps are WHO approval, as I mentioned, translation, collaborating with other centers to continue to do the work, and thinking of mechanisms for training updates as we have ongoing updates of the Icd-11 guidelines when it starts being used in the field. So I want to stop there to invite you to, if you find this a worthy endeavor, if you'd like to participate in the clinical, the online training rather, to join the Global Clinical Practice Network. And here is the website at which you can join. Again, I'm happy to send these slides with the link in them. I'm going to stop there. Thank you.
Great, thanks very much, Tahilia. So just on behalf of our department and the audience to say that it's just thank you very much. There are some questions going up already, and so perhaps we should take the first. It's from Professor De Vries, who's a child and adolescent psychiatrist, who says it seems there's been an emphasis on mental as opposed to neurodevelopmental disorders in terms of experts, field studies, and training modules. Could you please comment?
So that may be the case from kind of the subset of the papers that I referenced, but we have tried to have representation of all of those areas in the field study work that we've done. Some of our limitations have been in terms of resources, how many studies we can do at a time, but we have been doing studies around neurodevelopmental disorders. And you may have noted in the unit outline that I briefly shared, we are developing a unit. We have not, you are right in that right now, the priority has been in focusing on developing the mental disorders section, so anxiety, fear, schizophrenia, for example. But we are trying to be thoughtful about it, and we do hope we get the materials that clinicians, potentially such as yourself, who work in these areas, represented in terms of field studies, but also in terms of the online units available for this. One element of that is also related to the timelines or finalization of the ICD guidelines, which in itself is associated with the timeline of working groups, making the proposals. And so some of the lag that you may be seeing may be captured by kind of these lags in the development of the guidelines. So they weren't in ready yet for us to do the testing. But I hope that in 6 months, when we have all of the modules done and all of our studies done, that you feel more satisfied with our approach to neurodevelopmental disorders. Thank you for your question.
Chris is saying he's okay.
Yeah.
So it's really wonderful to have on the call people from outside the department. So special word welcome to Professor Allwood. Lovely to see you here. And then we have Professor Timming saying Icd-11 personality disorders are looking to adopt what DSM-5 did not accept in their AMPD model. What are your thoughts?
Yeah, so this alternative model of personality disorders, I do have to apologize. I do not want to speak too in depth about this because it's not my area of expertise, but I'm happy to follow up with additional resources and connect you with members on the working group that could more substantially and comprehensively respond to your question. But what I will say is that, as I mentioned, when developing the personality disorder guidelines, working groups that were doing that as part of the Icd-11 work had the benefit of proposals to the DSM-5 for personality disorder that were already prepared to incorporate into kind of the final model of what the Icd-11 looks like. And actually the personality disorder model is the next one to come out. And so it will likely be out in early April, maybe even sooner than that, because I've been actively working on editing the final pieces of it. And so I hope that you will take a look at the module and see whether we adequately addressed this specific question. As I mentioned before, I'm happy to give you my email address and connect you with people who can provide a little bit more of a scientific response to your question. I apologize that I cannot, I don't feel poised to do that at the moment.
That's great to hear. I mean, I think from my perspective, it's quite interesting that DSM-5 ultimately chose, they came up with a whole bunch of different ideas and then ultimately sort of stalled and didn't implement them, whereas Icd-11 has gone ahead and it seems to me to be quite a clinically useful way of approaching personality disorders, and so it'll be interesting to do the training module, and it'll be interesting to see whether this is adopted, perhaps, for example, in our neuroclinics, to see if it works locally. I see that Dr. Karen Maria has put on her screen, and I am thinking that she probably wants to tell us about a study that she's doing. Is that correct, Karen?
Unless anyone else has another question for Tahilia.
Go for it, Karen.
Okay, I'm going to try and share my screen. Let me just fix it. So thanks very much, Tahilia. I'm glad that you're allowing me to piggyback on your wonderful presentation. Hi, everyone. I just wanted to let you guys know about an exciting study that's happening in South Africa, but also in 4 other WHO English-speaking countries. I've been very fortunate to be part of a group that has been developing an instrument, a diagnostic interview that is actually based on the Icd-11. And we have been led by Jeffrey Reed, whom Tahilia has mentioned. He was the project manager of the ICD revision. And also we have in our midst Michael First, who is the author of the SCID-5. So we have been developing and almost done with the SCI-11, which is the structured clinical interview for the ICD-11. So for those of you familiar with these type of instruments, the SCI-11 is to the ICD-11 what the SCID is to the DSM. And so the study is not going to be about validity or reliability at this point. We just really want to test this instrument and see, is it acceptable to clinicians and patients alike? Is it feasible to implement it in research and clinical settings? And do clinicians find it useful, whether in state or private practice? And so I would love if people could volunteer if this sounds interesting to you. You can see my email and cell phone number at the bottom, and I'm happy to send this slide around as well with Tahilia's slides. And we're not expecting a lot. We only want you to interview 5 patients using the Icd-11 and then rate confidentially online your experiences with using the Icd-11. And so I think it's a great opportunity to give our South African perspective on this instrument, and the idea is that this instrument is going to be used globally. Thanks.
Great, thanks, Karen, and thanks for involving South Africa in your work. That's really awesome. So I'm just seeing if there are any last questions. Doesn't look like it. And so, yeah, I think that I'm expecting all our registrars to be fully versed in Icd-11 over the next year or two, and now they have the training modules that will enable them to do that. So thanks very much indeed, Tahilia, for updating us. It's really, as Dr. Kenna says, it's really eye-opening and good to be on top of where WHO is with psychiatric classification. So thanks very much indeed.
Very much. Thank you for your time.
Great.
You're welcome, sir. Thank you so much for the presentation.
Thank you. I appreciate it. Thanks.